Assalamu alaikum. Actually, this is a very generic subject. I think I cannot, I am really concerned that can I complete it in a very short time. I will try it for it. Actually, my topic would be that an update for the heart failure with reduced ejection fraction. And for that reason, sorry. Okay. The educational objectives are like that. So I will share something around very in short pathophysiology and recategorization of heart failure, and then I will try to summarize some of the contemporary pharmacotherapy and heart failure of the ejection fraction, including conventional therapy, newer pharmacotherapy, and some approach to the and very short with implantable device therapy, and secondary MRI in heart failure with the ejection fraction, and other few things in a very short time. So if you see that the heart failure really is a very serious disease, and it is more than something, sometimes more than cancer. Many of the cancer, you can see leukemia, 40% mortality rate, but above that, 48% is a heart failure patient. The another important aspect we see that if you compare the typical trajectory of heart failure with the cancer, you can see that initially the cancer may have a good life, but from the very start, heart failure will have a very downgrading point, and ultimately both of them will have a similar outcome at the end. The basic thing we must understand, should understand about treatment is the cardiac remodeling and pathophysiology. In short, we can say that this is basically an heterogeneous clinical syndrome, and we have got a very similar or several type of phenotypes, and this has got a very complex pathophysiology. But another thing you must remember, the heart failure is not only the disease of the heart, but it has got an integrated relationship with the rest of the body, and for which we must understand the pathophysiology in a very nice. So if you can see this figure on the right side, there are some sort of pathophysical insult, and that create some cardiomyocyte loss, cardiomyocyte hypertrophy, fibrosis, and then some of the insulin resistant cases, and electrophysiological abnormalities. And all these insults actually give rise to two types of adaptation. One is hypertrophic type, ischemic phenotype, another is hypertrophic phenotype. But ultimately, both the phenotype leads to a heart failure, means a dilated cardiomyopathy with a reduced ejection fraction cardiac output. If you can summarize all these things in a shorter manner, that the damage of cardiac myocyte and and other ECM tissues, they lead to cardiac remodeling. And this remodeling ultimately gives rise to cardiac output, reduced cardiac output. And this reduction of cardiac output actually stimulated the neurohormonal activation, especially everybody of us know that renin system, sympathetic nervous system, endothelial and vasopressin system. Initially, these systems actually have a very short time adaptive responses, and they reduce sodium retention, they reduce renal water retention, they also give rise to vasoconstriction, and they try to increase the contractility. But at the long term, there will be maladaptive consequences, and then that leads actually to myocardial oxygen demand, increased myocardial wall stress, myocardial stiffness, and ventricular remodeling. And these ultimately leads to the heart failure symptom, and mortality, morbidity is increased. But at the same time, I can see that there are certain systems like NP system, the natriuretic peptide system, other nitric oxide, CGMP. These are also cardiac regulatory systems. So initially, though, these two type of systems balance themselves, but ultimately with a maladaptive consequences, heart failure actually occurs. So if you can remember, you can recollect the fact of cardiac remodeling and reverse remodeling. So this, since the body is human body is a living body, and time to time it even changes. So initially, when you see the normal heart has got normal cardiomyocyte, myocardium, and morphological LV become normal. But when it fails, then every three important components actually reduced, and from here heart failure actually occurs. And what happened either with medication or in natural situation. We have got certain cardiac reverse remodeling to some patient. And this reverse remodeling actually has two types. One is myocardial remission, means they remit sometimes, but they can go back to heart failure. And there may be some cases where can have medical myocardial recovery. And once the myocardial recovery is there, possibly most of the patient can remain in the recovery phase. And with this, if we can summarize again, this is the fact that when heart failure occurs in where the heart failure, the ejection fraction is less than 40% after remodeling, then there may be, we can use medical therapy or device therapy or sometimes surgical therapy. Sometimes they can reverse back to be a normal, we call recovery phase. If there is partial recovery, we can call it myocardial partial remission. And if there is no remission, so there will be no recovery. So this is the how. So heart failure situation pathophysiologically is a dynamic process by itself, and also it changes with its prognosis with medical and surgical or device therapy. So if you can summarize all these things, that we have got starting from the risk factors to the advanced heart failure, and everywhere, in every stage, we must have an effective therapy, either to prevent or to improve outcomes. And there are certain diagnostic tools which can use for assessment and progression, like echocardiography, imaging, and everything else. So this is the compact progression of the heart failure, and we must remember that at the early stage of heart failure, if you can institute our treatment, we can have better life. But recently, there are new categorization of heart failure. We can say that the heart reduced ejection fraction with the topic of today, reducing the mid-range ejection fraction with preserved ejection fraction, and the very newly added with the recovered ejection fraction, where ejection fraction previously was less than 40%, but was improved with medication or medical therapy more than 40%. This is the thing. So each of these patient groups observe a specific approach of management. So we must understand the diagnosis of hypertension, and we must categorize heart failure in their rubric, so that we can appropriately tailor our physiotherapy or pharmacotherapy or other therapy. Management actually, we need a multimodal treatment modality with several drugs, devices, and intervention as appropriate in the patient. But the key important to the successful management will be the prompt diagnosis in the community, proper management in the hospital, and of course, there should be a proper evaluation follow-up measure. Heart failure actually have got a pharmacotherapy. I have summarized in this form that management of this is the mainstay of pharmacotherapy includes actually diuretics, beta blocker, and RAAS inhibitors. But more recently, there are new pharmacotherapy for heart failure. One is SGLT2 inhibitors, guanylyl cyclase stimulators, and very recently, cardiac myosin activators has emerged as the new tools which can improve outcome of the patient. In summary, actually, I'm not going to detail because every one of you know that conventional pharmacotherapy actually have got 4 classes of drugs. One is ACE inhibitors, ARBs, beta blockers, and mineralocorticoid receptor antagonists. So they have got motility benefit in different studies. Most of them. And like ACE inhibitor is there in state B, they reduce actually 20% relative rate reduction. Like that, there are many. And there are recommendations for various guidelines. Say, for example, ACE inhibitor is a class 1 recommendation. ARB also similar to the ACE inhibitors. Beta blocker also a class 1 recommendation, and also MRI also class 1 recommendation for class 2 to 3 with ejection fraction less than 35. So one important aspect that this is the basic treatment, that's cheaper also, and we have got a definite evidence base for their use, at least in the conventional situation. So if you can compare this four group of patients, you can see the ACE inhibitor reduced to some extent 15 to 17% of mortality, angiotensin almost similar, beta blocker significantly reduced around 35%, and mineralocorticoid receptor antagonist also around 28% reduction. So we can see over there that these are the evidence from where we can use this 4 group of drug or 4 classes of drugs. The other pharmaceutical use, which usually used in the heart failure with reduced ejection fraction. In addition of those four are diuretics, hydrolyzine, isosorbate diuretic, and digoxin. Digoxin, everybody of us know, and diuretics also we have no, so I'm not going to detail. But diuretics has a class 1 recommendation in patient with fluid reduction, we must remember. And the hydrolyzine, this hydrolyzine and isosorbate diuretic combination is rarely used in this country, but in America and other countries, mostly the black people, with the black people, they have got class 1 recommendation in American African people population. And digoxin has no effect on mortality, but 28% heart failure revision is reduced in 3 years, and they show that they have got class 2A recommendations. So these are the conventional drugs, and some other drugs we use in heart failure. Now, see, what about the newer pharmacotherapy? You can start for 2014, the great study paradigm, heart failures in August 13, 2014, that actually used a newer field for heart failure treatment. And subsequently, there are a lot of other drugs, approved heart failure study in 2018, prime heart in 2018, and DAPA-F hypertension for dapagliflozin in 2019 and 2020. There are three important study, the Victoria study, Emperor Reducer study, and Galactoride study. So you can go very quickly. So newer pharmacotherapy over the last 10 years, we have got ARNI, sinus node inhibitor, evaporating, and more recently, we have got AGL2 inhibitors like empagliflozin, dapagliflozin, etc. And then glucuronide cyclase similar like derisoglutamate. And another drug is cardiac myosin advisor, omecamtiv mecarbil. So these are the fewer newer drugs that I'm going for quickly. Again, ARNI has earned a very important position nowadays for heart failure management. They has got a class 1 recommendation for NIH class 2 to 3 patients. Evaporatin has got a class 2A innovation only for patients whose heart rate is more than 70%. So of these two drugs, ARNI has got a class 1 recommendation. Now, when we compare with the RAAS inhibitors like ARB and AC inhibitor, so additional 20% mortality reduction has been done by the ARNI, use of ARNI in this patient. So gradually from conventional study therapy with the newer therapy, our outcome is being increasing. Now, the other drugs are AGL. I think you have got a very full lecture on it. I'm not going to detail. And they have got two large clinical trials and one meta-analysis. Actually, they found that this has got a consistency of benefit regardless whether the patient is diabetic or non-diabetic. So this agent should be considered a standard or foundational therapy in patients with heart failure with ejection fraction. And we have got this basically renovascular system action. But main action actually is go to either through glycosuria and to natriuresis. And from different aspect of them, I'm not going to detail, different aspects of the physiological system, ultimately vascular system and cardiac system, they protect cardiac. Similarly, with various other systems, anti-arrhythmic system, they also protect the cardiovascular. So in short, this AGLT actually is both cardiac and renal protective patient in heart failure, protective agent in heart failure patients. So that is an important aspect, and very nowadays it has got a very important recommendations. So this has got a very useful clinical trial, has given the very useful in broad spectrum heart failure severity, starting from 2 to 4, and of course, this drug has given the conventional therapy the improvement in the clinical outcomes. The indications are heart failure with reduced ejection fraction with or without diabetes. And we can use in NIH class 2 to 4. We should be administered in conjunction with the background guideline therapy in heart failure. We should use. So the second one is we call it soluble glucuronide stimulator. The main agent now used is very secure. And this mechanism of action, we know that in heart failure patient, they have got oxidative stress with inflammation. They have got developed endothelial dysfunction, and this endothelial dysfunction actually result in cGMP deficiency, and that gives rise to myocardial dysfunction and vascular dysfunction. What a very good or this SGC instrumental, how the action is? They enhance the sensitivity of the nitric oxide. At the end, I say also directly stimulate the AGC, and thereby they increase CGMP and contractility of the failing heart. So the oral stimulator ratio recently found to improve a good outcome in systemic high risk patient with heart arrest. And these agents, unlike nitrates, do not exhibit tachyphylaxia. That is an important point. They do not give rise to tachycardia. So the other drug is a cardiomyosin activator, very new class of ionotrope, basically. And this Mecarbil, which is Omen, you can see this picture. When heart failure occurs, actually they have got a very weak binding status. So they have got weak contraction, weak binding, weak contraction. They cannot give rise proportion. But if we give this particular drug, the binding is very tough, exaggerated, and they can improve it. And so that they prolong the systolic ejection time, increase cardiac contractility, and then increase cardiac output. Actually, and the important aspect of this is there is no change in calcium homeostasis and myocardial oxygen components like LV, DP, DT, they cannot increase. And this is being strongly, they can give rise to very strong actin-myosin complex linked to the increased contractile force. So this is the important. So the important trial of this particular drug is the omega study.
1 minute past, sir.
So another 1 minute, please. So I'm going to very short next day. Actually, okay. So nowadays we have got two type of drug classified. There's one is the conventional type, another the newer drug type. So this the other type is for everybody, and this is for personalized. So now the 1 year mortality when we will compare. Starting from the untreated to the newer drug, you can see starting from 70% mortality came down to 4.2%. After acute hospitalization, everybody should started either the RAAS or ARNI, RAAS inhibitor or ARNI, beta blockers, before they discharge. Once they have discharged, they have to follow by continued up titration and by either telemedicine or diet medicine should be given. So I'm not going to this thing in detail. The secondary MR, I must avoid it. Next, the advanced heart failure also I must avoid it. And now the palliative care and also says, but only 3 slides more. The recent guidelines expert concerns updates. The first expert is there is heart failure with the CTAP, and here they started with ARNI, ACE inhibitor, but they call it ARNI preferred. Then subsequently they add different drugs in different clinical situations like aldosterone antagonist, MRA, SGLT2, diuretic agent. Within 2021, very quickly they have got 3 important guideline changes and expert position. So this is the first one. The second one with the GHP. Here I can see that in the you can see everybody should they should start in conjunction with ARNI, beta blocker, MRA, and SGLT all together, and then subsequently clinically as after clinical assessment they can give rise to this. So the last one is actually this is the drug. They have got the British or also the European. They will call these 4 drugs as their fantastic 4 or 4 pillars of heart failure therapy, and everything should be started, and they should be arbitrated and optimized. And they can be additional treatment as per the side effect. I'm not going to detail. The last one is the key messages should be from this quick presentation, incomplete quick presentation is the progressive nature of heart failure with reduced ejection undoubtedly requires a multifactorial intervention. The recent research data with proven drug therapies offer new and effective treatment option for patients with heart failure with reduced ejection can be additionally flexible and individual. But you might remember that drug treatment must be flexible and should be individualized. There are indications that landscape of contemporary heart failure therapy is changing continuously. Thank you very much. I'm very sorry for the extra time you have taken. Thank you very much.
That's okay, sir. Thank you for your brilliant presentation and punctuate simply.